When approaching malposition, we want to remember the passage, so the mother, what is happening with the pelvic space, so the alignment of the pelvis, the musculature, the passenger, which is the baby, so what position is the baby in, and then the power. How strong are the contractions? How effective are they being with helping to influence the other two? So these three are factors towards labor progress. So if baby is OP or their back of their head is towards the back of the pelvis, either directly OP or either to the left or the right, the problem is that the sacral promontory, so where the sacrum and lumbar spine connect, is jutting in, and baby's head is getting caught on it. So if baby's head is getting caught on the sacral promontory, they tend to go into more extension or deflection as opposed to tucking their chin. So baby will be more like this or like this because that bony structure is preventing them from being able to move into the pelvis and then tuck their chin. The other thing to consider is the shape of the uterus. So because the uterus falls forward towards the beginning of labor, baby is also going to be in more of an extended position because of the shape of the uterus. So now we have both the baby's body is falling forward, not allowing it to flex, and it's hitting this sacral promontory. So we want to try to, one, move that bone out of the way so that baby can then tuck their head, but also facilitate them rotating. So OP positions are going to result in a deflection of baby's head, so baby's head's going to be more extended, and it's going to prevent them from descending into the pelvis. There's either going to be no or very little pressure on the cervix, and it's going to result in irregular, uncoordinated, and weak contractions. So baby's position and the contraction power are not lining up to move through the passage. So posterior arrest tends to happen around the 6 centimeter mark. Baby's still going to be high in that -2 to -3 station, and then you might start to notice swelling. So if your client or patient is kind of stuck at that 6 centimeter mark, baby has just not dropped, and then maybe they're also complaining of like really intense back pain, it could be an indicator of OP. In addition, if you did a cervical check, you could see, is baby's position OP? Also, you could look at the belly from the outside. Is it caving in a little bit more in the center? That could be an indication of OP as well. So what are some possible solutions to help alleviate an OP position? So first, you can either do an inversion where the legs are elevated above the arms, the forearms. So this can be done on the bed, it can be done on a couch, or you can do knee-chest position. So the chest is in front of the knees, but the chest, the hip joint here is going to be open. So it's going to be greater than 90 degrees. In addition, during the contractions, you're going to do a double hip squeeze. The reason being is the double hip squeeze is going to open the inlet more. So you're going to push up and in, and it's going to help open that inlet space just a little bit. In between contractions, you're going to do the booty shake with the scarf. So draping the scarf over the buttocks and then shaking it pretty aggressively in between contractions to help those muscles relax. So it's like when you get a massage and they shake your arm and then they tell you to relax. It kind of distracts the muscles and helps them release. So it is recommended to do sharper jerks on the side that baby is OP. So if baby is OP to the right, so the back of the head is towards the right side, when I reach the right side, I'm going to jerk a lot more with the booty shake to kind of help the fluids create this current to help baby then rotate with it. So either an inversion or knee chest position, so anything where the hips are elevated above the belly. In between, during contractions, you're going to do double hip squeeze, and then in between, you're going to do booty shake with more of a jerk to the side of the OP presentation. Another thing that you can do is an abdominal lift and tuck. So what that is the birthing person is going to grab underneath their belly. We're going to get full hip extension, so that way we have a posterior pelvic tilt. So full hip extension contributes towards a posterior pelvic tilt, which is going to move that sacral promontory out of the way. And then the birthing person is going to lift up and in to kind of draw their belly in, almost like scooping baby in, to help kind of align the baby better with the inlet. So we would first start with this, and then we would move to this to then help baby engage. We would do this for about 10 contractions. Other things that you can do is you can do a forward lean with an elevated foot of the side that the OP presentation is on. So if baby was OP to the right, leaning forward and then lifting that right foot onto something would help open that space more and help kind of tilt baby away from that side. The other thing that we can do as a comfort measure is doing hot or cold with a lot of really firm pressure. So usually a sign of posterior position is a lot of back pain, so more than usual. Remembering that a lot of the uterine ligaments attach to the back, so a lot of women experience back pain throughout labor. But posterior positions can cause more back pain because the position of the baby's head is pulling more on those uterine ligaments, causing more pain. So really firm pressure really helps with that, particularly in the low back area, because it's going to push that sacral joint in a little bit more, so that way the ligaments shorten and there's not as much tensity in them, and it's going to help relieve some of that pain. So OP position, the head tends to be deflexed and the baby cannot descend into the pelvis. Usually the arrest happens around 6 centimeters when baby is still high and could also be coordinated with some swelling. The solutions, anything where the chest is going to be below the hips is going to allow baby to move out of the pelvis. We're going to open the inlet more with the double hip squeeze. In between, we're going to do the booty shake with more of a jerk to the side of the posterior presentation to help with the flow of the amniotic fluid to help rotate the baby. And after that, we're going to move into abdominal lift and tuck for 10 contractions. And then after that, the birthing person is just going to do a forward lean, elevating the foot on the side of the OP presentation to help the baby continue their rotation. And the comfort measure is going to be really firm pressure, either hot or cold, on the low back.